talk to you today about autoimmune epilepsy, which is basically epilepsy syndrome caused by the immune system. These are my disclosures. We're going to go over the definition of autoimmune epilepsy and then how it's differentiated from other epilepsy types, the diagnosis, how to form it and think about it, treatment, and also some future thoughts. Before we talk about autoimmune epilepsy, we'll talk briefly about seizures. And seizures are excessive hypersynchronous brain activity. Basically, epilepsy is when the brain of a certain person is predisposed to have those seizures, and then epileptogenic foci, to be more specific, are the neurons or the group of neuronal networks that promote such seizures. Now, autoimmune causes for seizures have been debated and discussed now for more than 100 years, and there are animal experiments back in the 60s and the 70s of the 20th century that shows certain antibodies and autoimmune reactions can cause seizures. One of the oldest forms of pediatric refractory seizures, called Refractory encephalitis, was attributed recently to an autoantibody called NGLR3. GAD65 is another form of chronic epilepsy mediated by a certain antibody, or at least it's one of the thought to be involved pathways. Now, how prevalent is autoimmune epilepsy? We don't know that for sure, but there are certain studies that give different estimates. It is thought that about 5 to 7% of all epilepsy is autoimmune, and about up to 20% and even more of undiagnosed or idiopathic epilepsy are due to an underlying autoimmune condition. Now, this could be a little bit complicated, but the pathophysiology of autoimmune disease affecting the brain can trigger from different pathways, but it is interesting to know that the seizure itself can be the result of irritation or inflammation of the neurons, but it also can be the cause. So when there is damage in the blood-brain barrier or certain neuronal dysfunction or certain substance that gets secreted, whether that's due to a seizure or another trigger, and this can start an inflammatory pathway signaling to something called PAMPs and DAMs, which is the danger signal of the brain. This starts a pathway of receptors that ends up in something called NF-κB, and NF-κB is the main messenger that activates the systemic interleukins and cytokines, such as interleukin 1b, which is basically a microglia activation. These are immune cells that go in then and start an inflammatory cascade, and they also can invite other immune cells to the brain to cause inflammation. So it's a two-way process, and it's kind of a chicken and egg question. But the main thought about autoimmune epilepsy is that the immune system is the initial trigger. There's a primary antibody or primary inflammation that then causes seizures. But it's an interesting thought whether seizures itself can cause chronic inflammation. We'll talk about that a little bit more down the line. Now, our knowledge about those antibodies have progressed significantly since the 1960s, where the first antibodies group, now called ANNA1, used to be called anti-Hu at that time, were discovered in the 1960s. And since then, we used to say about one antibody every decade now because of increased technology and multiple research endeavors to look for these antibodies. We are able now to identify a new antibody every few years, and the syndromes have become a little bit more identified, as we're going to see again in the next few slides. Now, we truly don't know about the antibody prevalence itself, but seizure and epilepsy syndromes that happen due to immune-mediated mechanism are the major bulk of what constitutes to be an antibody-mediated or autoimmune epilepsy. So whether or not that constitutes a large percentage of autoimmune epilepsy or not, that is not clear, but it is thought to be due to the mechanism and the known knowledge. Now, whether the antibody is against the cell surface, and that will make it more likely that the antibody itself is responsible for the seizure, or whether the antibody is a bystander, which means that it is a cell-mediated inflammation, and the antibody is against the nuclear antigen, That is not known as the antibody in that case. It's pathological or just merely a product of the inflammation. Now, sometimes there's an underlying autoimmune disease or malignancies, such as lupus or certain cancers or rheumatoid. In that case, the immune trigger is known. However, sometimes it's totally idiopathic why this person would have an autoimmune antibody in their body. The International League Against Epilepsy, 2017, defined the autoimmune epilepsy as any seizure caused by the immune response against the brain, with seizures being the core symptoms. And this is very important because that differentiated from encephalitis. And encephalitis is a status of inflammation of the brain where the whole brain is inflamed and there is a plethora of symptoms that are neurological, including coma, altered awareness, certain motor, speech syndromes, and seizures can happen as part of this. Now, sometimes it can be very difficult because in autoimmune epilepsy, you can see also other symptoms such as cognitive decline with time, and sometimes they are overlapping. It is thought that about 33 to 100% of encephalitis patients will have seizures. But most of those do not last outside the duration of the epilepsy itself, of the encephalitis itself, apart from certain syndromes like LGI1 or GABA. Now, how do we become suspicious of autoimmune epilepsy? How do we think about it? Well, in the past, it used to be an assessment that is done by a neurologist or a specialist. And since then, there was an increased need for more systemization, and that's why there's a score that developed at 15 points called AMPA score, and that would give that indication that there's a possible underlying autoimmune disease to this seizure syndrome. And similarly, there's a score called DRAVET. Basically, it takes the same steps as AMPA, but in addition, it adds 2 more points, adding 2 more items, adding 2 points each. And this is, there was an initiated immunotherapy that lasted for 6 months in response to this and the detection of any neuronal antibody. And DRAVET and AMPA have been used increasingly with sensitivity and specificity that has shown to be different studies, but recently there was a score called the AMPA-2 score that added a little bit more to the original score to make it more sensitive and specific. And it is thought in one of the studies that was done by Hoag et al. 2019 that if a person or a patient has an AMPA-2 score of more than 4, then autoimmune epilepsy is likely. And then the next step would be to check for neuronal antibody. And if there is an antibody, then we're done. That's a definite one. We don't need any further work. But if it's negative, then a score of 4 or more will qualify the patient for immunotherapy. And if there is improvement of immunotherapy, then this is a probable AE, and we assume that continue the treatment, but there is no effectivity for that first-line immunotherapy, then a score of AMPA-2 of 7 and more at baseline makes it again probably that they have an autoimmune epilepsy. It's worthwhile trying different types of autoimmune therapies or immune therapies. But if there's no response and the original score was between 4 and 6, then that's still a possibility, but it will be small, and whether or not it's worthwhile trying more for immunosuppression becomes debatable. So what do we use to diagnose autoimmune epilepsy in addition to the stuff we just mentioned? Well, there are certain tests such as, more importantly, the MRI of the brain that can show different hyperintensities, either in the basal, either in the medial temporal lobe, which we call a limbic encephalitis pattern, or in the basal ganglia on T1. Sometimes can cause cerebral or cerebellar atrophy, and that is more than what you expect in comparison to cerebral atrophy. EEG, which is a brain wave to detect seizure that can cause or show a certain rhythm called delta brush, which is known to be associated with NMDA encephalitis, for example. There are certain imaging techniques, such as a brain PET scan or SPECT, diffuser imaging that can show certain patterns suggestive of a hypermetabolic intake or suggestive of an inflammation. Now, when there is autoimmune epilepsy, the risk of malignancy is known to be associated with most of these antibodies, as we're going to talk about in a minute. And that's why a cancer screening with different measures as per standard is important. Now, here we're limited a little bit of what insurance allowances and what we can do. And now, basically, the follow-up and how often to repeat cancer screening is again debatable and depends on the level of suspicion and the approach of practice for the specialist, but usually it's agreed upon to be every 6 months to 2 years. But the duration for how long it lasts for is not well known or not well agreed upon. Let's talk a little bit about the different two types we mentioned about autoimmune or antibody-mediated epilepsy. We talk about the antibodies, which are again the cell surface, which are thought to be more of a causative agent here. The most famous now, most known is NMDR, which is N-methyl deaminase receptor, and that basically has a low risk associated with malignancy, apart from teratoma, that's associated in about 20 to 40% of the cases. Usually females are more affected versus the other type, which is called LGI1, which is a potassium channel blocker, if it's more male in their 40s. The NMDA is known to have a prodrome of neuropsych symptoms, psychological manifestations, then progresses to different types of seizures. And there's also reports of autonomic, like hyperventilation, and certain oral dyskinesias that are classically described in different cases, as described originally by Dr. Delmau. However, in LGI1, there's something called a facial brachial dystonic episodes. And if you see this for once, you know what it is, but basically it's kind of rhythmic movements of the hand and a corner of the mouth that can happen in the terms of focal seizures. Again, some autonomic dysfunctions such as piloerection, and the seizures again can be focal or general. Thymoma is again associated 10%, and 10% of the cases overall risk of cancer, about 15%. It is known that this potassium antibody can be associated with a different anti-potassium channel antibody called Caspr-2, which usually can cause peripheral or neurotoxicity or hyper-excitability syndrome, which is termed as neuromyotonia, can be detected on EMG and by clinical examination. The MRI in this case usually shows T2 medial temporal and basal ganglia T1 hyperintensity, as we mentioned before. And both of these syndromes have very good response to immunotherapy, however, with a reasonable risk of relapse. So follow-up is required. Then the next group will be what we call the GABA receptors antibodies, and these affect usually patients in their 40 or 60. The risk of GABA-B association with cancer is higher than GABA-A. They're both associated with a pattern of seizures called crescendo seizures that can be quite refractory. In GABA-B, small cell lung cancer is very common, while thymoma in GABA-A is common, and the MRI can be either a classical medial temporal limbic encephalitis pattern in GABA-B, but in GABA-A, it's rather scattered T2 subcortical lesions that are non-specific. GABA-B is a bit more resistant to immunotherapy, with GABA-A responding in 80% of the time. Now, another group of cell surface antibodies, we're still talking the same group. There's a group of antibodies called AMPA, and AMPA is associated in low percentage with small cell cancer, but thymoma is also associated in about 60% of cases. And limbic encephalitis is again the pattern clinically with focal or generalized seizures. This affects again female more than males, while MGLUR5, or what they call Ophelia syndrome, usually affects younger females with behavioral disorders, abnormal movements, and seizures. Ophelia syndrome is associated with Hodgkin's lymphoma in about 60% of the cases. Both have very good, excellent response to immunotherapy, but again, with recurrence rates way higher in AMPA than mGlu5. Cell surface antibodies can affect a group of inhibitory neurons called glycine receptors, and those share a lot of features with GAD65 antibodies. They even can cause that syndrome called PERM, progressive encephalomyelitis rigidity with rigidity myoclonus, with the thymoma again being a common association and a response rate in both this case and another antibody-mediated epilepsy called Neurorexin-3 in the 70s. Neurorexin-3 is interesting because it usually presents with a combination of acute confusion, abnormal movements, diarrhea, and hyperventilation, sometimes mistaken for poisoning or SSRI syndrome. And the response to the response is good, but the association with cancer and the cancer is not very clearly detected. The risk of seizure is very high in these cases. So this level of suspicion for this antibody can be high when a female presents with such a syndrome. Now, DPPX is another interesting anti-potassium voltage channel antibody, which affects male in their 50s, way higher than females. And this is, again, an interesting presentation that can affect the GI symptoms because it also targets the enteric neurons, and it can cause abnormal movement, ataxia, cerebellar syndromes, and cognitive decline, with seizure present about 20% of the cases. This also can cause this PERM syndrome. The association usually is with B-cell tumors, and the recurrence rate and relapse rate is very high, and responsiveness to immunotherapy can be modest. So unfortunately, in these cases, they become steroid dependent, and once trying to wean them off the steroids, the risk of recurrence of symptoms will become high. Cas2 antibody, we discussed that briefly as a second potassium channel antibody that can be associated with peripheral neuromyotonia. And when it affects the central nervous system and peripheral nervous system, it causes something called Morvan syndrome, where it can cause seizures of any type, with limbic encephalitis about 90% of the time. Thymoma, again, it comes as a theme here, I think, today with most of these syndromes, is 16 to 19% present, and the response to immunotherapy is excellent with a very high recurrence rate. And again, you can see that the high recurrence rate with potassium channel blocker antibodies seems to be a feature. Now we're going to talk about a different group of autoimmune epilepsy, and these will focus about intracellular antibodies, which means that the antibody identified is against an antigen that's inside the cell, not on the cell surface, meaning that probably there's a different immune reaction destroying the cell, exposing the intracellular antigen, causing the immune system to make these antibodies as bystanders. And these usually are thought to be associated with underlying malignancy cases. So thought to be more paraneoplastic, such as the AMPA-Q, which is 70% of the time associated with small cell lung cancer, anti-Ray, which is a brainstem disorder, it can cause Joe, dystonia, stridor, and again, more than 70% associated with small lung cancers. In anti-Ray, it's a brainstem disorder, so the seizures are rare. Most of those can be quite refractory to immunotherapy, and the same thing continues with small cell lung cancer or germinal cell cancer, and can cause an antibody syndrome causing limbic encephalitis called anti-MA, either one or two. Seizures are rare here, but again can be very refractory. CRMP5, it's an interesting syndrome of basically brainstem involvement, can cause cranial nerve ataxia, in addition to spinal cord involvement called myelopathy. So one of the few causes of paraneoplastic myelopathy is CRMP5. Seizures can be aware seizures as in partial or unaware focal seizures. Again, lung cancer and thymoma are associations. Rare antibodies causing causes of seizures that have been identifying recent new antibodies, and as we said before, there is an increased rate of those antibodies being discovered, such as GFAP antibody, which is a meningomyelonencephalitis refractory, can cause refractory seizures. IGLUON5 antibody is a new antibody, again, a rare manifestation that can cause a sleep disorder, such as REM or non-REM with nocturnal seizures. AK5 is a new cause of encephalitis recently identified. Now, the prognosis here is difficult to identify, but as we said, or we can notice that if there's association with cancer, it's refractory to immunotherapy, and certain syndromes have higher recurrence rates. So usually most patients with slow surface antibody encephalitis have seizures that don't last for a long time and they can be treated. However, about 15% will have chronic epilepsy and can be refractory. And certain disorders such as LGI1, for example, if we find CSF titer of the antibody itself high, especially that IgG4 subclass of the antibody, that means it's a worse outcome. And in the encephalitis, if the EEG pattern shows a delta brush rhythm, then it's a bad prognostication sign. And there's also a function called NEOS that can identify or predict the status functionally at 1 year. Now, what about non-antibody mediated seizures that caused by inflammation of the brain? Diseases such as MS. Well, in MS, seizures happen in about 2 to 77.5% of cases. Not a huge percentage, but given the prevalence of MS, this is also a significant number. And usually those happen because of lesions that affect the cortex and become a photoepileptogenic focus. In NMO, which is another demyelinating disease mediated by anti-APO4 antibody, it's rare to have seizures here at about 0.7 to 1%. And there's a new entity, a cousin of NMO, if we wish, is called the MOG because it's named after the antibody, oligodendrocyte-glycoprotein antibody, and here seizure incidence can be high, up to 14%. Other inflammatory diseases of the nervous system, which are non-demyelinating, such as neurosarcoid, which is caused by granulomas that can grow in the meninges and in the brain parenchyma itself. Seizures can be the presenting symptom and also can have high prevalence in that syndrome, up to about 15%. In vasculitis of the nervous system, focal seizures can happen as part of the symptomatology due to the inflamed blood vessel in the brain. Now, Rasmussen encephalitis, we spoke about that briefly. Initially, Rasmussen encephalitis is described in the 1950s, a very rare refractory epilepsy syndrome of the pediatric group, thought to be associated with a certain antibody called mGluR3, but other neuronal antibodies have been identified, can cause focal aggressive epilepsy that sometimes requires a splenectomy of the brain, separating the two hemispheres from each other to stop seizures. Now, how do we treat them? There's no trials, so all these therapies are off-label, and most of them because of case reports or expert opinion. But the first line of therapy is always agreed upon to be IV steroids unless proven otherwise or to be contraindicated. This can be followed by plasma exchange, which is successful in reducing the surface antibody titer about 80%, and an intracellular antibody titer is about 66% in certain studies. There's also studies that shows intravenous immunoglobulins to be an efficient way of decreasing the number of seizures. And immunoglobulins are a group of antibodies collected or pulled down from blood donors, and the plasma from those donors are precipitated, and then they is made into those bags, if we wish, of IVIG that's given to the patient, that they can tackle the immune system by different methods, depends on the receptors on their surface. Finally, there's a third-line immunotherapy in refractory cases in the acute setting, using different depleting or cell-depleting therapies such as rituximab and anti-CD20 that is used sometimes to, or even used for a long time to treat inflammatory diseases such as rheumatoid or lupus and other off-label uses. cyclophosphamide, which is an alkylating agent that can affect multiple cell lines, lymphocytes, or even myeloid cell lines have been described to be effective in these therapies. The future, as we spoke before, tell us a little bit more about autoimmune epilepsy. And the question so far has been whether or not seizures and refractory seizures can be accompanied or associated by some sort of chronic inflammation induced by the seizure itself, and that prevents the seizure to have a good control. And as we said, it could be a chicken and egg phenomenon. And there's ample literature now and studies about the role of immunotherapy in resistant mesial temporal sclerosis epilepsy and other type of different seizures, and whether or not immunosuppressants can help controlling some of these refractory seizures. I think these are very interesting topics for the sake of the future. And the idea is that we still know very little about the interactions between the immune system and the brain. We are in the phase of discovery when it comes to these antibodies. As we said, there's a lot of unknown. We don't know if some of these antibodies are the main causations, what triggers them. We also don't know what about those intracellular antibodies and whether there's another immune ignition that can cause cell damage and then those antibodies will form. What about other cell-mediated or granulomatous, demyelinating diseases? We don't know much about those. I think in the future, we will see more studies that will tell us about the mechanism behind many of those seizure disorders, but it would be beneficial now for many neurologists, even general practitioners, and the public to know about the association between autoimmune mechanisms and seizures. And it's always very important when it comes to idiopathic or difficult to control seizures to apply maybe the ACE2 score and have that in the back of our mind whenever we deal with a difficult case. These are some references about the articles I talked about. Thank you.
Hi there, this is Yair, Jassam, a neurologist and MS specialist,